I'm very pleased to have with me honors alumnus, Dr. Gary Loyd, currently an anesthesiologist with, is it the Ford Medical System in Detroit?
It's a Henry Ford Health System, yes.
Henry Ford Health System. Well, before we get into the primary topic of our conversation, which is, of course, the COVID-19 health crisis, tell us a little bit about yourself. You're a 1982 honors graduate at the University of Kentucky. What was honors like in those days?
So it was an amazing eye-opening experience for me. I went through high school, which was very math, science oriented, very practical. And so I just happened into the honors program thinking that it was just going to be advancement of the current types of classes that I was in. I was in for a very amazing, rude awakening that there was something outside of math and science, and the opening my mind to ideas and the history of ideas just totally changed my life and opened the avenues to really to expand and be more than I thought that I ever could be. So it was
and when
nice
you
program.
and when you took honors at the time, it was I think a 4-course sequence, wasn't it? Freshman, sophomore year of sort of great ideas courses.
Yeah, so there was 4 basic courses that you took, but then there were additional classes that I latched onto after the first semester when I realized that this was important and I needed to understand more about what was going on. So yeah, so I took more than just the 4 basic courses.
Excellent. Our curriculum is a little different now, as we can talk about another time, but it still is rooted in that idea that it's the broad engagement with complicated problems and issues that build our leaders, and with our foundation course that every student must take now, which is an epistemology course. What is truth and knowledge, and how do we acquire it? Should then suffuse everything they do. And as somebody who wanted to be a real doctor, that is a physician, and didn't make it, but of the real doctors that I've known, such as yourself, and that is so much of what you have to do, really, right? It's not just a medical problem. It's not just a science problem. It's social science, it's politics, it's culture, it's community. And it seems to me that our current situation sort of exemplifies that in spades. Before we get to that, I shouldn't have jumped to it. So you went to med school at Louisville, right?
Correct.
And you spent time as a professor of anesthesiology. That became your area of expertise.
Yes.
What led you there? I mean, because you've won a number of awards and are highly decorated, but anesthesiology in particular, what drew you to that area?
So I originally was going to be either pediatrician or family practitioner. And I did a rotation in anesthesia during my 3rd year clerkships because it didn't have any prerequisites in it. And I started out that way and just lucked into it, fell in love with it. I took advantage of my strengths, which were anatomy, physiology, pharmacology, and nothing else really compared. And so that I did it full time. And have never looked back and don't regret it 1 minute.
Excellent. And you've taught in Florida, taught and practiced, of course. In Florida, you were at the West Virginia University. Is that right? Yes. Before going to Detroit?
Yes. So I was in Louisville. I was chair at the West Virginia University for 2 years, went back to Louisville for a few years, and then went to the University of Florida at Jacksonville to start a new program, which at the time was a concept, which was perioperative surgical home. So it was cutting edge. It took advantage of all the honors types of things that I had been working on throughout my career. So it was something to do towards the end of my career. Instead of like taking the easy retirement path out, I chose to do something challenging, and it's been extremely rewarding.
I saw that on your CV. What is perio-optic? What is this?
So the perioperative surgical home is a concept where silos are broken down. So as you're going through your perioperative surgical experience, It starts at the time of referral to a surgeon to the time in which you get well sometime after discharge. And so it's a continuity of care. So everybody on the team knows what's going on. So it's not just a doctor, surgeon writing some orders and somebody else doing their part and other. It's all done together, and the care pathway is created. Everybody in the path knows what's going on, and the care pathway is created with the best science available. And so everybody is challenged to change the current practices to the highest level of evidence. And then every patient gets the same level of care throughout the process. So, well, we've been able to do this with every service line that we've worked on. We've cut morbidity and mortality at least in half.
That sounds great. It sounds like what a friend of mine shared about what MD Anderson has been doing in Houston with some of their cancer treatment. Is that a similar project, or is that something different?
Yes. Yes, and actually I'm collaborating with some of the people at MD Anderson on some of these pathways as well. So yes.
Oh, great. So let's dive in here, because there's been a lot of conversation in the news, not just about the virus, of course, the novel coronavirus, and then, as I understand it, to be precise, COVID-19 is the disease which results from the virus. Is that correct terminology?
So COVID-19 is just coronavirus. It was discovered in 2019, so that's what the name comes from.
Okay, so I thought I'd heard some scientists make a distinction between the virus itself and then the illness that one gets.
So there is a pulmonary illness that comes with it, which they'll call the COVID-19 pneumonia.
Oh, I see. Okay, all right. So that's the specificity. Now, as an anesthesiologist, I mean, you're obviously deeply engaged in this, I would think, because there's been so much discussion around the virus and then the need for ventilators. As I said, sort of being adjacent to medicine, my mother was a nurse, but actually very personally, my father passed away a year ago, next week, in fact. But Dad, in his late stages after a stroke, they put him on a ventilator, and he passed away. We weren't able, when we took him off the ventilator, he just wasn't able to sustain himself. So lately in the news, while there's been all this discussion about us not having, we in the United States not having enough ventilators, the conversation in NPR stories has shifted to, well, that's really a last stage treatment anyway. So can you clarify for me at what point a ventilator is needed, what really becomes a prognosis if someone is going on a vent, and that engagement?
Yeah, so I'll give you like some general numbers. So we have at Henry Ford thousands of patients who have tested positive. And
Wow.
if you don't qualify to be sick enough to be admitted to the hospital, then you're sent home. Mm-hmm. And then we call you about once every shift to check on you. Good. And then those who are sick enough that they need oxygen support and other support will be admitted to the hospital. And the oxygen is because the pneumonia that you get from the COVID virus just has fluid that's building up in your lungs, and you're not able to get the oxygen in through your lungs into your bloodstream. So if we give you extra oxygen, enriched oxygen, then you get more in there. When you get to the point where just your breathing by itself is not enough to get the oxygen in, then we need to put in a breathing tube and assist with the ventilation to expand the lungs more and suction out some of those secretions and to allow more oxygen to get into your blood. So that's what the point of the ventilator is. It just assists in getting that oxygen into your bloodstream.
So, and actually, I want to go back and ask you a more basic science question. So is it that our lungs are responding, trying to fight off the virus that's causing it to secrete and therefore fill up with fluid, or what's causing the fluid, the pneumonia in the chest?
Correct. So it's your body's reaction, and it's an inflammatory response which causes lots of fluid, just like any other injury to your body where it swells. Right. This is swelling inside. So it's the fluid buildup from that, plus all the white cells and everything else that accumulates during this battle between the body and the virus.
So when a body, and not to be morbid, but to try and have a better real understanding of what we're hearing in the news, when a body gets to the point of not being able to sustain themselves, um, I guess the phrase would be, what would the morbidity rate be at that point? What's the likelihood, the prognosis, that once someone goes on a ventilator, that they'll be able to successfully overcome that and get off a ventilator?
So part of it's dependent on genetics. That's why some people with no
Uh,
other, health illnesses that are in their 20s and 30s are dying. Then there's another piece that has to do with smokers.
mhm,
Smokers are at higher risk because every time you smoke, you break off the little cilia that's in your airway. That's your elevator system to get all the secretions normally out of your lungs. Well, if you don't have, if they're broken off, then you don't have that there. That's why smokers have a smoker's cough that part of the way takes care of that, but doesn't totally. So it puts them at higher risk.
mhm,
The whole point of the ventilator is to allow the expansion of those lungs, because you have something that's called surfactant, which
mm,
allows the each little air sac in your lung to easily open up. Otherwise, they're like pieces of plastic that are wet that stick together.
mm,
So the
mhm.
surfactant creates this sort of oily thing between them that allows them to separate and not get stuck together. And when it's fighting this virus, that surfactant gets diluted or eroded, or the cells that produce it aren't able to produce enough. And so all those little air sacs stay together. So when you get on the ventilator, there's extra pressure pushing in that pushes those little sacs open. And so that allows more oxygen to get into your blood.
Thank you very much. Now, from your perspective, what are we not hearing? What are those of us watching the news and reading need to know? Because my understanding is, I mean, not just your expertise, but Detroit, your area, you said you have thousands of cases in the Henry Ford system. My understanding is Detroit is really quite hard hit right now. What do we need to know?
So everything that you need to know is actually being put out in the news media, but you should pay attention to what the CDC is saying.
Hmm.
There's a lot of political sides that people are taking. There's also a lot of rogue scientists that are making assumptions about a few studies that are really not correct. So you need to look for where is the truth. And the
Hmm.
CDC is working really hard to make sure that that type of truth, Johns Hopkins and other reputable places, are actually producing the truth. I would say away from the political side of things. So just to give you the perspective, so right now we have, I think the latest data we have is like we have like 890 patients admitted in the hospital right now.
Wow.
We just sent home 729 people who have now improved, who we've been able to save their lives and get them discharged.
Mm,
But
wonderful.
having 890, we've had 124 who have died
Mm,
in the hospital. So once you get admitted, it's the morbidity really starts to stack up. But then when you take the
mhm.
thousands of patients who were not sick enough to get admitted, the mortality rate really does drop down to closer to 4%. But once you get admitted, it goes up around 15,
Well, and
16%.
right, and my understanding is we'll not have a true number. Well, we may never, because we don't really know what the denominator is, not having tested,
Correct.
and with the likelihood of people having it but not showing symptoms, very light symptoms. Is that right?
Yes, but we'll eventually probably know because we'll develop good antibody testing, so we'll know how many people actually had it.
Okay, so
And
we'll go through a process of testing people, even if they're healthy, to kind of come through and
yes, so we'll eventually get what that actual mortality rate was.
so. I mean, it looks like well, I mean, I remember the conversation as it was emerging from China, that so much of the goal initially was to try not to let uh, COVID-19 get a foothold, to not become like the flu. Putting on your predictive hat, do you think that COVID-19, this particular strain, is such that we're probably going to now that's going to get folded into the mix of annual flu shots, and it will just become a part of what we're trying to prevent, like measles, mumps, and rubella, and flu, and so forth? Is this here to stay, or is this going to be more like SARS and H1N1 that will eventually disappear? I think I either lost you or you lost me. Are you back, Dr. Loyd? There you are.
You froze up. You're still frozen.
Oh,
Oh,
well, you had frozen for me. It was me.
Yeah, so you started your question and then you froze. So I'd never heard the question.
So my question was, when this first kind of broke in the States, the goal was to try and keep COVID-19 from getting a foothold and becoming sort of a normal part of our routine, the way in which the flu shot is today. Do you think that now the prospect is that COVID-19 will become like measles, mumps, and rubella and flu shot, these things that we treat, or will it be like H1N1 and the prior SARS that went away and we haven't seen recursions of?
So we don't know enough yet. We're going to learn a whole lot now because China is starting to reopen its economy. And when it allows the people to interact socially again, we'll see whether they get a new spike and it comes back again. There's some indications of other places that have done that they saw a spike after allowing social interaction again. So we'll really find out from that. We don't know enough about whether, if we really contain this enough, whether it will actually just die out, not have any host to be, or whether it's actually going to sit and linger around to spike again. So we'll find out. We really just don't know. Plus, we don't know what interim treatments would be acceptable. Lots of different things are being tried, but yes, it could end up being like mumps and rubella, and that we should have vaccines. But of course, we're going to have people that are not going to want the vaccines, and so they may be carriers forever.
Exactly. Well, back where we started on discussing honors, it is sadly a really great example of how complicated life really is, right? This is so much of what we try and talk about is if only everything was a discrete problem. Here's a chemistry problem, here is an economic problem, but all of these are in fact involve all sorts of factors. So from your perspective, as you think about the social, political, economic, environmental, and so forth, what are some of your reflections and takeaways of how this is developed, and your, not just your role as a physician, but looking at the way this impacts every aspect of our lives now?
So the whole idea of acting as a collaborative team is more underscored than ever before. We can't work as pockets and individuals. We can't be working in competing areas because we have this crisis. So people have opened their minds and their efforts and dedicated themselves selflessly and working with others to try to defeat this. And I think we're learning how to be stronger as a society by doing that. Everything is connected, and we really understand how it's all connected. Even in the healthcare arena, we have the whole perioperative surgical home where we're trying to break down silos. All those silos are gone right now. What anybody asks that has any knowledge about what's going on, everybody says how much you want of it and when do you want it, and I'll try to do my best, and they're bending over backwards to make it happen. It's pretty incredible. And like when I go to the grocery store, it's an entirely different mindset. That's a group of people who know they're putting themselves at risk, but they're taking the appropriate precautions, but they're also extremely mindful of everybody around them. The whole mindfulness piece is extremely important for all of us.
Yeah. Well, actually, there's one other real practical question I wanted to ask you, and it's, as we're recording this, is very much in the news. And as somebody who is directly working with what goes in and out of our bodies and how it affects us, the masks. What is your professional view on what people like me, if we go into a grocery store, say, what should we be doing? What should we, I mean, other than preferably staying out of, of stores,
Yes.
but in terms of the whole mask conversation.
So look at your math. I mean, the virus is 0.02 microns,
Yeah, I was
and
going
like
to say.
yeah. So and a coffee filter filters down to 20 microns. There's different testing you can look on the internet now for what is. So the best mask you can get is, again, the N95, but you can, wearing a mask decreases your chances of inhaling the virus, period. And the better the mask, the better the protection. So my advice is nobody should go in public anywhere without some kind of mask on.
Okay.
Even if it's a coffee filter mask that you made at home out of rubber bands, that's what you should be wearing. It's we protect each other this way, and yeah. And the better your mask, the better protection you have, but it's also the better protection for somebody else, because you don't know if you're a carrier. And everybody needs to be thinking that they're an asymptomatic carrier as well. And if you want to treat your fellow man appropriately, you don't want to share what you have with them.
Well, thank you very much. That actually had been a burning question I meant to ask right at the top, and I appreciate your frank and practical guidance and advice. Dr. Gary Loyd, anesthesiologist, and with the Henry Ford Medical System and a University of Kentucky Honor alumnus. Thank you very much for joining me.
You're welcome. It's been a pleasure. Thank you.